Hi guys, so this lecture is going to be looking at two neurological hearing disorders, auditory processing disorder known as APD and auditory neuropathy spectrum disorder known as ANSD. So we'll start with APD. So first of all, I want you to have a go at trying to figure out what these sayings might be. They are familiar ones. Maybe try saying them out loud. Think about what they might be. Okay, so we have the translations of those sentences, and really this is just to give you some thoughts or an idea of what it might be like to have APD. This is how people describe APD. Words running into each other, losing the intonation or the wording of sentences, not being able to understand what's being said. With auditory processing disorder, it has got a long but very controversial history. And the controversies around it are really around some of the really big fundamental types of issues. So, what's the definition of APD? What's its neural basis? Are the tests used valid for diagnosing the condition? How can the tests be standardised so that they're the same for everybody? How do we differentiate APD from other disorders which have quite a similar presentation, like dyslexia? Is it really an independent disorder? Is it a disorder in its own right, or actually is it just part of another condition? It's characterised by poor perception of both speech and non-speech sounds despite a normal audiogram, and it's rooted in impaired neural function in both the afferent and efferent pathways of the central auditory nervous system. APD impacts on everyday life through reduced ability to listen and therefore inability to respond appropriately to what has been heard. We need to remember that hearing and listening are two different things. So hearing happens when your ear detects a sound, but listening is the active part of that process. So when somebody presents and is suspected of having APD, they will typically report having listening difficulties, and greater difficulty hearing in noisy environments, history of mishearing speech frequently, needing lots of requests for repetition, so it doesn't matter how many times someone repeats themselves, it's still no clearer or easier to understand. And also they may present with poor attention to or poor memory of auditory instructions. There's three categories of APD which have been recommended and are generally accepted internationally. So these are developmental APD, acquired APD, and secondary APD. So for developmental APD, it might be due to some kind of developmental disorder, probably diagnosed in childhood, but it could be one that is appearing at a later age as listening environments become more complex. So as people progress through the education system or if they start work, that's when a problem is identified. With acquired APD, these are cases associated with ageing or some kind of known medical or environmental event such as having a brain lesion. Secondary APD, this is for cases where APD occurs as a result of either a transient or permanent peripheral hearing impairment. What you should know is that in the literature, most of it focuses around developmental APD, primarily because this may contribute to learning difficulties around language and literacy and cause poor school performance, so that's what makes it a really hot topic. So how do we diagnose or assess APD? Well, this is the difficult part. Okay, there's no international consensus on what tests should be done. It's generally agreed that the tests currently available are not suitable, as they are primarily tests of language and auditory attention, but they lack sensitivity and specificity for deficits of auditory perception. Okay, so there's hundreds and hundreds of tests that can be done for APD, but actually the thought is that they're not quite diagnosing what or assessing what it is that they think they are. It's recognised internationally that there is a need to develop a smaller battery of tests that are well validated, have normative data, and are relevant to those who are presenting in our clinics. However, when an APD assessment is being performed, there should be a case history. This is to understand the difficulties experienced and its impact on work, on social interactions, and other achievements. Questionnaires that would look at assessing listening skills, although actually there's none currently available that are suitable for adults. PTA and tympanometry should be tested as routine. This is to rule out any other kind of underlying hearing problem. And speech perception tests, both in quiet and in noise, should be performed as well. Although what those tests should be, that's what's unclear. It's well recognised that a top priority for further research and development should be around APD management. Currently, the intervention strategies can be divided into three main categories. So these are modifying the listening environment, auditory training, and compensatory strategies. Okay, and you can find all of these written out like this in the BSA position statement from 2018. Auditory neuropathy spectrum disorder, or ANSD for short. There have actually been many names that have been used for this condition in the past, but it's now recognised as auditory neuropathy spectrum disorder. This is following the Como conference in Italy in 2008, where all the experts on auditory neuropathy from around the world, they came together to discuss the condition, and one of the things they discussed was what it should actually be called. ANSD is a hearing impairment where the cochlear outer hair cells appear normal, but the neural activity in the auditory pathway is disordered. So in short, the cochlea is working, but the nerves aren't working well. It's often described by people who have the condition as listening to an out-of-tune radio. So some things come through clearly, some things are really distorted and muffled sounding, or maybe listening to a phone line when you've got a really bad connection. Now, auditory neuropathy in the literature, again, it almost always relates to children. We're much better at identifying ANSD in children, particularly since the introduction of the newborn hearing screening programme, where hearing is tested on everybody automatically in England and Wales at birth. The majority of cases of ANSD, more than 70%, have other associated medical factors that might explain the ANSD. So often it's seen in babies who've been in neonatal intensive care units with things like extreme prematurity, hyperbilirubinemia, and oxygen deprivation. But it's also known to have a genetic link in the otoferlin gene. Now, in the adult population, it is more seen in certain patient groups, such as those with rare conditions that affect the nervous system, and these could be either hereditary or acquired. So how common is ANSD? Well, the answer is really we don't know how common it is in the adult population, probably because generally this population don't have such thorough diagnostic assessments as what we would do on an adult. As we do in the paediatric population. So generally adults will just have some kind of PTA done. They won't have ABRs and cochlear microphonics and OEs and everything like that done. We do, however, know a little more about the paediatric population. So out of children diagnosed with a permanent hearing impairment, it seems that around 10% of these will have ANSD, although take this with a bit of caution as the numbers do vary significantly from study to study. It's thought that in the at-risk population of babies who've been in special care, around 0.2% of them will have auditory neuropathy, and this data is taken from the NHSP report. So what is affected when someone has ANSD? Well, it can be one or any combination of the following parts of the hearing system. So it could be the inner hair cells, the synaptic junction of the inner hair cell and the junction of the auditory nerve. It could be dyssynchrony of the auditory nerve causing disruption to the signal, underdevelopment of the auditory nerve, impaired temporal resolution, so timing cues, auditory neurons in the spiral ganglion or the brainstem auditory nuclei. It's characterised by normal cochlear function of the outer hair cells, but dysynchronous auditory brainstem responses. So our OAEs and our cochlear microphonics are present. These are tests of the cochlea, so they're working fine. But there's neural impairment, and this is evidenced by an abnormal or absent ABR, as well as absent or abnormal acoustic stapedial reflexes. In terms of your audiogram, these people could present with anything. Okay, so some people with auditory neuropathy spectrum disorder will present with a normal audiogram. Some will have a fluctuating hearing loss, some will present with a profound hearing loss, but what we always find is that speech perception is impaired beyond what you would expect for their degree of hearing loss. So if you looked at their hearing levels on paper and then assessed their speech perception, it wouldn't be wouldn't be representative of what you'd expect it to be. So people with a normal audiogram would have significant speech perception difficulties despite that normal audiogram. Now, these guys in 2001, they looked at the audiological profile of people with ANSD, and the first thing that they found was that the ABR was absent in 70% of cases. They also found that the audiogram for people with ANSD was very variable, as we were just talking about. They looked at the changes in hearing thresholds over time. They found that although many had no change in their hearing, there were examples of people who had fluctuating hearing, progressive hearing, improving hearing, or even temperature-sensitive hearing changes. They also looked at the configuration of the hearing loss. Again, they found this to be variable. For lots of people, they just had a flat hearing loss, but there was also people that had low-frequency ones, high-frequency ones, and other shapes of hearing loss too. In terms of speech discrimination, as we just mentioned, the worse the hearing levels, the worse the speech discrimination scores, although there are exceptions to that, and it's still performance is significantly worse than their sensorineural counterparts. So with ANSD, the hearing levels from the hearing test do not predict their speech perception difficulties. And we know that they're going to present differently to people with the same level of sensorineural hearing loss. The way that this can be different are, first of all, in the noise effect. So in ANSD, some people will show normal understanding in quiet, but inability to understand in everyday listening conditions, both in background noise and when sounds occur one after the other with short succession. Intensity discrimination, so that's the ability to perceive the changes in loudness. For sensorineural hearing loss, we'd expect to see some recruitment or disrupted intensity perception, but actually for ANSD this is fairly normal, just like people with normal hearing. In terms of frequency resolution, the ability to separate the components of a complex sound by the cochlea, again this would be poor for people with a sensorineural hearing loss because of the damage to those outer hair cells, but actually it's fine with people with auditionopathy as the problem isn't based in the cochlea, it's in the nerves. With temporal resolution, that ability to perceive changes in stimuli over time. In sensorineural hearing loss, this would be normal, but for those with ANSD, this would be severely affected, so the degree of disruption is correlated with their speech perception ability. And frequency discrimination, the ability to perceive changes in frequency over time in sensorineural hearing loss is usually disrupted, but it's going to be much more severely disrupted for those with ANSD, particularly in the low frequencies, and that's where we get our temporal cues from, where that's important, so that kind of ties together. Management of ANSD is tricky because we can't just go off their audiogram, we can't go off what their hearing levels are like on paper. So we use that to guide our amplification, but actually we want to look at their functional hearing ability. How are you actually managing? And that's how we're going to aid you, not what the PTA says. Okay. We know also that hearing aids aren't going to overcome those temporal problems that they might experience. And so the outcomes can be really variable. So somebody with a moderate hearing loss could get on quite well with a hearing aid, really well, or really, really badly. It's not going to be the same for each person you see with ANSD. What's really important is that we are looking to assess their speech discrimination ability, so looking at how well they are understanding speech and trying to work with that and see if we can make any improvements to that. Something that is likely to make an improvement, what we do know is that the use of a radio aid or an FM system can be really helpful for people to enhance their hearing ability in a noisy environment. So by using radio aid, where the person you're trying to talk to has a microphone, and this streams that sound from the microphone directly into their hearing aids, it means that it sounds as though the person is stood right next to you. So if you are attending a lecture, the person that's hosting the lecture will sound as though they're stood right next to you, even though you've got lots of people making noises in between you. If you're in a meeting, around a table, it will sound as though the person sat right next to you, even if you're at the other end of the table. So that can be really useful to improve the signal to noise ratio for the person listening. It might be that cochlear implants are appropriate. Now, this is a tricky one, but just because someone's audiogram suggests that they're not suitable for a cochlear implant, in cases of ANSD, it doesn't mean that they're not suitable. So it could be that somebody who presents with a really mild looking hearing loss who has ANSD could be suitable for a cochlear implant if their speech discrimination is poor enough. So part of the cochlear implant referral criteria is their PTA averages, but it's also their speech intelligibility how well they can understand speech. So if they're not doing very well with that, it could be that they could do better with a cochlear implant. They should at least be referred for consideration. So in summary, people with ANSD are likely to have greater difficulty understanding speech and distinguishing one sound from another than someone with similar hearing levels, particularly when there's background noise present. It's often described as a distorted or unclear signal, so like that untuned radio where you can hear bits of what's being said, but it's not always clear and there's other sounds interfering. When you see somebody with auditory neuropathy, they really could present with any level of hearing loss, any configuration or shape of hearing loss, and that could vary over time. And what we need to do is manage the patient based upon their functional ability, not on their hearing thresholds. Okay. So that may be that a regular hearing aid isn't suitable for them, even though on paper it looks like they should be. So we should be thinking about assistive technology that might help, like radio aids or even potentially a cochlear implant.